Good afternoon, everyone, and my name is Grace Suva, and I am one of the members on Implementation Science team here at the Registered Nurses Association of Ontario, and I'm going to be the moderator for today's Best Practice Champions Information Sharing webinar. I'd also like to introduce you to Andrea Stubbs. She is a project lead for the Champions program, and she'll be online to help anyone who has any technical questions in relation to today's webinar. So today, I'd like to introduce you to Karen Campbell, and today she will be focusing on pressure injury prevention and treatment in the context of resident-centered care. Before we get started, just want to keep some housekeeping items in mind. First off is that we do want these webinars to be interactive and engaging, and so the presenter, Karen, is going to be presenting for about 20-25 minutes, and then as you see on your screen, there is a chat box, and please feel free. We'll have about 10-15 minutes to ask Karen any questions that you may have, and so you can either write them in the chat box as we go along and as you have them, or when I announce that we're open for Q&A, you could also present your questions at that time. We also have started to record these presentations so they can be archived for future viewing, and it'll be available on the RNA website, and Andrea will also send everyone who is online today a copy of Karen's presentation. So it is my pleasure to introduce you to Karen Campbell. She is a BSCN, MSCN, and PhD and has a certificate as a tertiary care nurse practitioner. She's also an NSWOC member, and she's an RN. She currently is the adjunct faculty for the Masters of Clinical Science in Wound Healing at Western University in London, Ontario, and she is the president of the International Skin Tear Advisory Panel and a consultant with Primacare Living Solutions. She has functioned as an advanced practice nurse in geriatrics, wound care, and continence. She's also a co-chair or panel member on several best practice guidelines, as well as the assessment and management of pressure injuries for the interprofessional team. And she has a strong interest in geriatrics, skin health, and frequently speaks and publishes on this topic. I've also had the pleasure of working with her on the Wound Care Institute that is coming up in March. And she is one of the founders of the Institute, which has been going on for about 13 years. And herself and Laura Teague are content experts who have helped to support the development of the curriculum over that time. So Karen, welcome, and thank you very much. And I'm going to pass on the floor to you.
Thank you, Grace, and thank you to everyone who has joined us today. And I'm going to share my screen, actually, so that, I can control the slides and I can go back and forth.
Yeah.
Alrighty. And so this is a topic that when we were talking at Primacare, I've been consulting and helping them over the last several months, we thought is very relevant because often as clinicians, you're faced with, on one hand, best practice guidelines and wanting to implement best practice guidelines, but on the other hand, you may have residents and or patients who want something different than the best practice guideline. And so I'm just going to share some thoughts. I have a really interesting case that's very relevant, and I'm sure you can all relate to this concept. So first of all, I'm just going to give a very quick overview of what resident patient-centered care is all about. I'm actually going to do, again, a very high-level, broad overview of what best practice guidelines are for prevention and treatment of pressure injuries. Then I'm going to give some suggestions for how do you handle this? What happens when you have a patient or a resident that wants to do something that's contrary to best practice guidelines? And I'm going to make some suggestions for approaches. And then lastly, in the case that I'm going to present, we ended up with a situation where we had pressure injuries that were not healable. So I'm going to just review the concept of non-healable wounds, first of all, giving you a definition and then talking about how do you treat these. So how do we go forward and provide care to this individual? And I'm sure you can all relate with other examples from your own practice. And so I put up a picture of a heel pressure injury just to remind us what this is all about and what the focus of this session is. So resident or patient-centered care in its simplest form is a care model that invites, accommodates, and respects residents' wishes in healthcare and lifestyle decisions within the care routine prescribed either by the physician, the nurse practitioner, or other healthcare providers. And it could be, you know, the dietitian, it could be the physio, it could be really anyone on that healthcare team who's involved with the patient. And now I'm putting up this slide to show you the paradigm that we use when we talk about wound healing, and I've labeled it overview of prevention and treatment of pressure injuries, but this model actually could relate to any wound. And so you see at the top you have a person with a wound, and in the case that I'm going to present, our particular resident had pressure injuries, but was also at risk for developing more pressure injuries. And so probably the cornerstone of any treatment or any prevention is dealing with pressure shear. How do we offload the pressure? How do we reduce or eliminate shear? How do we manage all of the medical comorbidities that often these people have? So whether it's hypertension or cardiovascular disease, how do we improve their nutrition? And we do that when we look at things like, you know, where the person is lying or sitting. So beds, chairs, cushions, commodes, bath chairs, and but as well as looking at the cause and trying to prevent or treat the cause, we have to think about what the person-centered issues are. And the example in this slide is pain, but it could be quality of life versus quantity of life. It could be, you know, what a person that has children that they're taking care of, and their focus is, you know, raising and caring for their children rather than treating their wound. And once you've been able to identify and potentially look at interventions to, you know, to treat the cause, and in this case, it's looking at pressure, friction, shear, managing comorbidities, managing nutrition, we have to then look within the context of what this person is willing to do. Are they willing to collaborate with us in terms of all of these potential interventions? And that helps us as clinicians determine whether or not then this wound is potentially healable, whether it's a maintenance wound, and whether it's a non-healable and or palliative wound. And as I go through the talk, I'm going to be defining those in more detail. And once we've determined then whether or not the wound is healable or not, we start looking at things like local wound care, and these would be things like dressing selection, debridement, management of infection and or inflammation, looking at moisture, looking at the edge of the wound, but we're doing that always in context in terms of treating the cause. And so I bring this up because as I start talking about the case, you'll see how relevant that is. So in our case, we have an 85-year-old female who was admitted to long-term care after a lengthy stay in acute care, in a rehab hospital, and in assisted living. She was competent to make her own healthcare decisions, but she did wish to have her sons involved and wanted them to be aware of what was going on and what decisions she had made. She had a meningioma at T10. She had refused intervention in acute care, and that was a decision that she stayed fairly firm with. Because of that refusal to care, she had a paraplegia secondary to this tumor. So she was an elderly woman who has a new paraplegia. She had been in many healthcare facilities before she came to long-term care and started staying with us. As well, she had other medical comorbidities, so chronic renal failure, hypertension, elevated cholesterol. She had osteoarthritis, urinary retention, obviously secondary to her paraplegia. She had pitting edema, secondary to immobility, and she was admitted to a long-term care home that I was involved with 3 pressure injuries. And so this is a picture of one of her pressure injuries on her heel. And you can see that she's got, an unstageable pressure injury. She has a lot of dead and flaky tissue around that. And that was one of the wounds, one of the 3 wounds that she was admitted with. And so I was involved with her assessment and making treatment recommendations. And although we had to treat the 3 pressure injuries, we also had to prevent pressure injuries on other parts of her body. She was, wheelchair bound. That was, a new thing for her. There were nutrition issues. The dietitian was involved. And there were days when she would eat, most of her diet, but there were days when she chose to eat other things. She did require a special mattress when she was in bed. As I was saying, when you're dealing with pressure and shear, you have to look at wherever that person's body is over a 24-hour day. So she needed a mattress for when she was in bed. She needed a specialized and customized wheelchair and customized wheelchair cushion. And when she first arrived, she didn't have that. She needed offloading for her one heel pressure injury, but also to prevent the other heel from developing a pressure injury. So you can see we were involved with both prevention and treatment. Now, when I saw her, she had fiber-filled booties, but these did not offload her heels. You need to be able to actually lift the heel either off the bed or, and when she was in the wheelchair, we needed to make sure there was no pressure on the heel when she was in the wheelchair. She didn't like the offloading boots. She found them hot. She found them, because they were hot, she kept asking the staff to take them off. She also had a lot of edema, as I said in my previous slide. And edema, whenever it's present, either in a limb or in any part of the body, puts wound healing it really is a barrier to wound healing, because oxygen and nutrients do not like to diffuse very far, and so one of the recommendations is that we used compression on both of her legs so that we could get the swelling down. In terms of her prevention, swelling actually puts the tissues at risk, because you can end up with skin stretching, you can end up with weeping, and you lose the barrier function of the skin. So we needed, for ideal prevention and treatment, she needed to be wearing the offloading boot, and she needed to be in her compression bandages, which was a problem. She wanted to live her life. She wanted to be up and about. She wanted to be out, involved in all the programs within the home, attending, garden parties and activities, and didn't want to go back to bed at, say, after lunch for a rest, just to get her out of her wheelchair until we had a better cushion. And so you can see with this situation, we have a big problem, because we are not able to really treat the cause very well. We're not offloading her heels. We are not offloading her, coccyx, ischial tuberosities, and we're not dealing very well with her edema. The other issue, again, for her was quality of life. And so she wanted to be able to live her life. She wanted to be able to eat what she wanted to eat. So again, we have this difference of opinion. And, who am I to say that's right or wrong? That was her wish. And so this is what the coccyx ulcer looked like. You can see that she had other ulcers on her backside that had healed. You can see the scarring that's there. And whenever you have scar tissue, that tissue is not as strong as normal healthy tissue. And so you know then that that is at further higher risk for breaking down. So again, I just bring you back to this model of wound care. Here we have an 85-year-old lady who was a new paraplegic. She wanted to live her life the way she wanted to live her life. She said to me one day when I was seeing her, "How much time do I have left?" And that was not a question that I had an answer for, but I said to her, "That's a very good question actually to ask, and you're going to need to talk to your physician." So ask for the physician to come and meet with her. So she was already questioning, you know, how much more time do I have? She wanted me to talk to her family. I actually took pictures of her wounds to show her sons. She wanted them to be aware of what was going on. So you can see though, we were not able to treat the cause very well. We were able to treat some things, but when you had to consider some of her patient-centered concerns, we weren't able to treat everything. So, you know, the big question is, this is a common problem, and I know all of you who are on this webinar have probably dealt with this many, many, many times. And so I'd actually like to hear some of your thoughts as we go through this webinar. But first of all, the first step is the patient competent? So are they able to make that decision, first of all? And because resident-centered, patient-centered care is based on the present, on the concept that the person is capable of making that decision. I think the second most important thing is to have a collaborative relationship. Often in my field, when we go in to see patients, we make a whole bunch of recommendations. So, you know, we tell people what they need to eat. We tell them how they're going, you know, how their day is going to be, when they need to be up, how often they have to turn. We ask them, you know, to stop smoking. Now, that wasn't the case in this situation. We may ask them, we may take away some of their coping strategies and think about it, made 10 recommendations, and that can be quite overwhelming. And so you need to have a relationship, because if you walk in and you're a stranger and you do an assessment and you have this kind of barrier between you and the patient or resident, are they likely going to listen to you if you just come in and just tell them this is how you're going to have to live your life now, versus having a relationship that's professional but that is collaborative? You know, how can we work together? Is there one thing that you'd be willing to do initially? And the other thing that I think residents, patients need to be aware of is that they need to know of all the risks and benefits. I've had patients or residents say to me, you know, they assume that if they refuse a treatment or an intervention, their life will continue as it is now. But in the case of this lady, we knew that those pressure injuries were going to get worse. She potentially would develop more pressure injuries. They could potentially become infected. And then, you know, all of the potential risks that can happen. And so people really do need to be aware of all the potential risks and also the benefits of doing or not doing what we are suggesting. You also always need to assess for and treat depression. And I think as nurses, we're at the front line. And so there's, you know, steps that we can take in terms of doing that assessment, but potentially referring to, you know, psychiatry, physician, nurse practitioners to actually treat the depression. And that can be a huge, you know, barrier to wanting to collaborate and work with you in terms of wound healing. And then think about a self-management approach. And RNAO has a fantastic best practice guideline on self-management. I'm going to kind of go through some of the highlights of that, but also involve the family so that the family is well aware of what is going on, because otherwise it can be a terrible shock to family to all of a sudden see a huge problem and have been totally in the dark all along about what's been going on and what that person has been deciding or not deciding. So I like the RNAO BPG on self-management because it utilizes the 5 A's. So the 5 A's are assess, advise, agree, assist, and arrange. And when you're assessing, you know, they talk about establishing rapport, and that's what I was talking about, having a relationship. Screening for depression, screening on regular interviews, and following up in terms of treatment. Establishing a written agenda. So when we meet, what are we going to talk about? Like, what's the focus? In this case, it was prevention and treatment of her pressure injury. And then also assessing the readiness to change, because people may not be ready today, but they could be ready in a week or two. And we're not all ready to change at the same time. And when you're assessing that readiness to change, they may not be willing or wanting to change 10 things, but maybe they'll be willing to change one thing. And that I'll talk about in a little bit more detail. So when we're advising, we need to combine effective behavioral, psychosocial strategies and self-management as part of this. And RNAO suggests use the ask, tell, ask approach. So ask the patient, what do you want to learn about your pressure injury? The person could say, well, I want to learn about nutrition. So you tell them about nutrition. You don't necessarily overwhelm them with 10, 15 different interventions, but you provide information that they're wanting to know about. And to make sure that they understand what you've just taught them, you use a communication technique, which is called closing the loop. So, you know, the patient or resident wants to know about nutrition, and you provide appropriate information about how nutrition impacts wound healing, and then you ask ask the person to repeat back to you what they understood, so you know whether or not they actually have a adequate understanding. You may need to fill in the blanks if there's some things that are missing. And then you agree. And so you need to agree on establishing goals. And it may not be, the 10 or 15 things that you want, but maybe it's 1, 2, 3, maybe even 5. And develop an action plan that is set up so that those goals are actually achievable. And then, monitoring progress towards the goal. So for example, the goal could be that, the individual works with the dietitian and improves their nutrition. And that the individual is willing, their goal is that they will take, 2 pudding supplements a day. So now that is actually, a goal that you can monitor. And if you have an achievable goal, there's more likely to be success, and you're more likely to have more buy-in from the patient or residents. There's a technique called motivational interviewing that I'm not an expert in it, but there are courses on it, and you should really think about taking a course on it if this is an area that you're interested in. But it actually uses a very helpful approach for how you can motivate people to make changes. We also need to teach and assist patients or residents to use problem-solving techniques and arrange regular and sustainable follow-up. So I've got a couple of questions. we will be sending out a copy of the presentation. I've provided it to Andrea at RNAO, and she will be sending it out to you as a PDF, but very good question. So I said I would help you kind of sort out these terms that we use in wound healing, which is healable, maintenance, and non-healing wound. So healability is a term that we use to indicate or to categorize whether a wound has the ability to heal. And it's either healable, maintenance, or non-healable. And interventions will vary based on what that assessment is. So if a wound is healable, there'll be a certain set of interventions. If a wound is non-healable, there will be potentially a different set of interventions. So why do we use this? It actually helps us in making a more accurate diagnosis and develop a fairly realistic individualized treatment plans. And it's extremely important because when individuals make choices that potentially are different from what we know as best practice, you know, we're not able to fix everything. And so those potentially could either be maintenance or non-healing wounds. And so we need to be able to separate those out. We've got a couple more questions in the chat box. Okay, will we receive a certificate of completion? I have no idea. And Andrea will answer that question. Thanks a lot. And so pressure injuries are classified as maintenance in situation where the patient or resident either refuses to treat the cause or where a health systems error or barrier exists. So for example, you need to offload, but there's no offloading available. The person has edema and they will not wear compression would be another example. But in that situation, when it's a maintenance wound, if the circumstances change, potentially that wound can become healable. So if the individual says, no, I won't wear the compression bandages because they're too hot, which is what my particular resident did. But if in a week, you know, they change their mind and they're willing to, you know, to wear the compression bandages, that wound could turn from maintenance to healable. And a non-healing pressure injuries refer to wounds that are unable to heal. And this may be due to an inadequate blood supply, the inability to treat the cause, and or wound exacerbating factors that cannot be corrected. And in the case that I presented to you, it was determined to be a non-healable wound. And now this is what you saw the before picture. This is what is the after picture. What happens when people do not offload their pressure injuries in the context of, you know, multiple medical comorbidities. And obviously, you know, the resident was a new paraplegic and therefore did not feel pain. You or I, if we have sensation, it would hurt. And that would be a cue to us that there's a problem here. You know, I'm sitting too long and my bottom hurts. And so, but in the case of this resident, because she was a new paraplegic, she wanted to live her life. This was the outcome of her choices. So we still have to care for and we still have to treat patients, residents that have non-healable wounds. So you need to really identify the goals of care and focus on these. And there was a bit of a struggle with this case in terms of once she had refused treatment for her initially her meningioma, so now we're down the road a year and a half, and that has progressed. We have now new pressure injuries, and I've got more questions here, so I'll stop for a second. Here we go. Just more questions. Here we go. From someone: in considering clients' choice and best practice, I've dealt with residents who are incontinent, and we usually change them in the night so they are not sitting in urine or smearing stool, but some residents would rather that we do not wake them up. Yes, and sleep is more important to them. And do you know of a minimum for when a resident should be changed? For example, is it appropriate to leave a resident in a potentially incontinent for 8 hours for the sake of sleep? That's a very, very, very good question. And I know it's a question that I think is worth further discussion. What I'm going to do is I'm going to finish my presentation, and I'm going to come back and answer that. Let me just see. Was the resident? Yes, she was showing photos of her wounds, and so was her family. And I have a paraplegic who has a long time. I'm assuming she has, or he has, 4 non-healing wounds: left and right ischial and left trochanter and coccyx. She loves to have her shower 3 to 4 times a week, therefore getting her wounds wet. And we've been using patient-centered approach with her by allowing her to have a shower against our advice. Her wounds are not getting better, and we're struggling at minimizing her risk of infections. What do you suggest? Another good question. I'm going to bring these up at the end. And can you clarify, is moist wound healing not recommended for not wound healings? That is correct. Rather than using moist wound healing, we dry those wounds out. Question is, how do you determine if the wound is healable, maintenance, or non-healable? I'll just go back, and it's all based on your assessment. So let me go back and explain to you about. So essentially, you need to look at all of the barriers to wound healing, and you need to understand, have we been able to treat the cause? And if you've not been able to treat the cause, and in this case it's pressure, shear, and friction, the wound is not going to heal. You can put gold, silver, and frankincense and myrrh on the wound, it won't heal. You need to treat the cause. You need to deal with nutrition, you need to deal with pressure and shear, you need to deal with edema. If you're unable to treat the cause, that would make the wound either maintenance or non-healable. Now, the difference between maintenance and non-healable is that if you're able to potentially reverse some of those, the patient or the resident in 2 or 3 weeks realizes that maybe they've made poor choices and are willing to change, it can go from a maintenance wound to a healable wound. But if there are so many barriers to healing, and in this case there were multiple barriers to healing, then that wound may be non-healable. And I think I answered the question about, we do not use a moist wound healing in this case, we use moisture reduction. So we use things like antiseptics, and we try to dry the wound out. We don't use expensive dressings. Please don't put expensive dressings on a non-healable wound. Focus on drying out the wound and preventing infection. You may have a goal of care in terms of pain reduction, and the care plan is much more conservative, and interventions are really focused on comfort and quality of life. And essentially, we try to reduce the wound drainage, and we would only use conservative methods of debridement. We're not going to be aggressive. We're not going to go in there and do really aggressive interventions. It's totally contraindicated in that situation. I'm going to summarize, and then I'm going to go back to the questions that were asked because they were very good. So with resident or patient-centered care, best practice may not be implemented. And we've looked at how we can collaborate with residents and patients. And I would also add in here families. and consider the use of self-management techniques. Determine if your wounds are healable, maintenance, or non-healable. And I would strongly suggest that you have family meetings to keep families involved. If the resident is not capable of making those decisions, then it would be the family or the substitute decision maker, power of attorney, that would be making those decisions. And if they're making decisions that are resident-centered, contrary to best practice, they need to be kept in the loop. You know, a family meeting is an excellent way, I think, of putting all the cards out on the table, getting the physician's input, getting the nurse's input, getting the family and patient input, getting the physio, the dietitian, you know, social work potentially, everyone. And so I put in a Halloween picture, and for those dog lovers out there, where are my questions now from the chat box? Here we go. We had some really good questions. So back to the resident who doesn't want to be awoken. So number one question, is that resident capable of making that decision? Kind of yes or no. If she is capable or he is capable, then you need to probably sit down with that person. I would potentially do it with, you know, the nurse, potentially the nurse manager, the physician, just to make sure that they're aware of all the risks and benefit of developing, for example, incontinence-associated dermatitis, and how that's a risk factor for you know, pressure injuries, and then making sure that that is very well documented. It's also probably useful in this situation, if you're quite concerned about this, is having a family meeting. Again, with you know, the resident, the family, so that they're kind of in the loop as well, and all of the team members that are relevant in that situation. And that may involve, you know, people like social work as well, potentially, if the person sleeps for, you know, 7.5 hours, you could do a incontinent care change and, you know, pericare at, you know, just before they go to bed, and then 7.5 hours until they wake up. But what you bring up actually is the situation that if the person has given you 100% informed decision and they want to sleep, and they're aware of all the risks of doing that in terms of developing skin issues, wound issues, and they still choose to do that, and you've got all of that well documented, then they have the right to do that. And, you know, that is their right. And so, but I would go through several steps before I got to that final decision, and I would make sure that it's all documented. It's in their care plan, you know, the family meeting is in the care plan, and so on and so on. And so then the second question is a paraplegic patient that gets in the shower. I actually use the shower to clean pressure injuries, and so it's a very good way of actually cleaning those wounds. You would need to make sure that she is the last person of the day to have a shower. Again, the question is she capable of making that decision? Kind of yes or no. Is there a way that you can use her request for the shower, but then also irrigate her wounds? And if they're irrigated and your water supply is safe, it actually will help to cleanse the wounds and you know, potentially reduce infection. And so think about too, are these wounds, you know, healable, maintenance, or non-healable, and make sure that she's aware of all the potential, again, risks and benefits, Make sure that's all documented in her chart. Is her family involved? Do they need to be involved? Is it important to have, you know, a family meeting so that everyone's on the same page and everyone is aware of what's going on and there's no surprises for the family? In the case that I told you about, this family was involved and had seen pictures. And so I didn't want it to be a shock or surprise. So question, this is home care and PSWs. So are not allowed to touch dressings. So they're leaving wet dressings on. Okay, so is that the same person? Yes, that's the same person. Thank you, Rose. In that situation, I wonder if the nurse can do a visit after the PSW has actually done the shower, or there can be a visit to change the dressings, or there could be a combined visit. And if that's not possible, then sorry, I was just focusing on the next question. If that's not possible for them to do the visit at the same time or right after, again, you need to think about, are there, first of all, is the person capable? Are they aware of all the risks and benefit? Is there a dressing that we can put on that wound that will kind of seal everything in place, kind of yes or no? And the nurse would know that better than I, because I don't know this patient, so that the dressings don't get wet. That would be another option. And I know showering can be an important quality of life for many people. And then, you know, lastly, are these healable wounds? Are these maintenance wounds? And if they're maintenance or non-healable wounds, we need to think about what are the goals of care. And in again, I'm making assumptions and I don't know this case, but your patient would be the best person. You know, the goal of care may be for her to have her shower 3 or 4 times a week and not heal the wound. So hopefully I've helped you with that. The other thing I would do is get your, in home care, you have access to wound expertise. I get your wound clinician to come in and, you know, potentially help with this and potentially work with your patients. So question, are you recommending our residents go to bed during an afternoon instead of sitting all day long in the chair? It's actually very good to be able to offload people so they're not up in a wheelchair for 12 hours. In long-term care, there's an issue with using tilt to offload at times. It can be seen as a restraint. And so sometimes what we do is we get person back into bed, you know, they have their lunch, we help them to digest, get them back to bed for an hour to offload out of their wheelchair before we get them up again. And you know, the other option that is done, if this works with your PDSA policy versus restraint policy, is using offloading for a short time period to tilt the person back in their wheelchair, to offload them off of their pressure injury, but not to use it as a restraint. And so, but I know, having worked in long-term care, this can be an issue because it can be seen as a restraint, and there is a whole procedure that you have to follow to make sure that tilt is seen as a therapeutic purpose versus a restraint. So we have, and I think we're almost out of time, but I have a last comment. I'm always concerned about, at the same time, agree that pathetically, there's a lot of staff shortage. Yeah, absolutely. And you're trying to do the best you can. And so thank you. Thank you.
All right, thank you very much, Karen, for that presentation and being able to bring to the forefront the complexity of wound care and being able to address person-centered concerns as well, and looking at the whole person. We have a couple more minutes. I think we're pretty much, if there's any outstanding questions or else, I think we're going to be closing up. Again, you'll be sending, you'll be receiving a link to an online survey to evaluate today's presentation. So please, we encourage you to be able to do that. If you have any questions with regard to today's presentation, please email astubbs@rnao.ca. Oh, we have one more question here.
I see it. So are we using maintenance and non-healable interchangeably? No, we're not. And I'm going to go back and show you a maintenance wound basically is in a situation where you could potentially change the intervention. So here we go. So pressure injuries are classified as maintenance in situation potentially where the patient refuses, but then could either change their mind. So, no, I'm not going to offload, wearing heel boots, but you think that you could get them to change their mind. Or there could be a healthcare system barrier existing. You don't have access to the heel boots, let's say, as an example, but you're then able to get them. And it's a situation where you think it could change. Often, though, we're dealt with non-healable, where there's so many factors and that you can't fix everything.
Okay, excellent. And Kelsey will also share this PowerPoint presentation to everyone who's online today, so you have reference to that. And I see there, Karen had referenced Sybil et al.'s article, which I'm not quite sure if it's open access, but that's a source that you can go to. Or Karen, you could probably go to the, well, I know the assessment and management of pressure injuries for the interprofessional team. The RNAO guideline has descriptions of the non-healable, healable, and maintenance wounds. And
it does, yeah, absolutely.
Yeah, and then also the NPUAP website as well, which is where we had referenced that information. Alrighty, so thank you very much, everyone, for participating in today's webinar. And thank you, Karen, very much for your presentation and for sharing your expertise and a case study. That was excellent. Have a great afternoon, everyone. Bye-bye.
Thank you.
You're welcome. Thanks, Karen.